very pleased to introduce our host for this conversation, Peter Horton. Peter is a longtime friend and colleague, known each other since we stood in line at the same event in 2003, I believe it was.
Way back before COVID, yes.
Yes, far before
way back then.
And welcome, Peter. Peter is a director, writer, producer, and actor. I know I admired watching him on 30-something back in the day, and we're really pleased to have you here with us, and has been a longtime writer, producer, director since then, Grey's Anatomy, all sorts of fun shows, Dirty Sexy Money, and now, of course, New Amsterdam on NBC, which I've been really enjoying watching. And we were actually, the Sun Valley Institute was going to be hosting an event with New Amsterdam with Peter and his colleagues back in March. But then, of course, the pandemic hit, so we had to cancel that. So, Peter, we're so happy to have really another take on that conversation that we were going to have back in March, live in person, here virtually. We're so honored to have with us in the room Peter, as well as Terry O'Connor, physician, as well as Lisa Wing, who's the head nurse for Bellevue Hospital. So I'll let Peter introduce your panel. But Peter, I just want to thank you for joining us again here live online, and look forward to your conversation.
Well, Amy, I got to say before you sign off or disappear, don't have to disappear, by the way. If you want to stay, we'd love to have you. I just want to say a couple of people have mentioned the word humble, how humbling it is to be here. I think Jeff said it, and maybe Eamon. And it's really, really true, especially in this moment. I mean, first of all, congratulations for pulling this off in the midst of all this insanity, you and your team.
Thank you. Thank you.
And it's somehow a little more moving for me because to see all of these not only intelligent people, but really good people, good-hearted people coming together in these unstable times, trying to stabilize the world, trying to do the right thing is really, really moving. So thank you so much for doing this. Really appreciate it.
Thank you very much. So all of you guys who make it.
And, I just want to say, well, first of all, just a technical point. If you have questions, go ahead and put them in the comments section here, and we're gonna collect those as they come. And so when we go to a question and answer session afterwards, we'll try and get to as many of them as we can. But thank you also, Amy, for letting us have this discussion. This situation, it's a big, acute, complex, even scary subject. But one that we're hoping to rip off the headlines and try and humanize it in this discussion. And who knows, maybe if we're successful, maybe even find a little bit of healing. So what are we to make at this moment? We're in a pandemic that crosses borders, national, personal, religious, political, yet it's become political. Even crosses racial borders, yet it's become about race, even racist. It's become a rich-poor pandemic. Has become a liberal-conservative pandemic. So what are we to make of this moment? Like most of you, I'm an outsider. I'm a person who's trying to do my best to isolate, to stay away from my friends, my coworkers, hoping to do my part to help us all get through this. Yet I have a conservative father-in-law who's also a doctor who feels like this was primarily media hype. It's an overblown yearly COVID event. Or I have a neighbor who feels like the numbers that the hospitals, the numbers are exaggerated because the hospitals are counting every death as a COVID death to make money. And so here we are, a divided nation on a certain level over something that so needs us to unify. With millions of infected, 125, 130,000 dead in the U.S. alone, not to mention the world, and a world economy on the brink. So what are we to make of this moment? In the past, we've gotten through these moments through resilience. We did so by coming together, whether it was the Great Depression, World War II, 9/11. We're at our best when we're united, which we frankly proved at the beginning of this. When this first came out, we all got together and tried to do the right thing. We isolated, we stayed home, we did everything we could, and by some accounts saved millions of lives. But yet the divides persist. And with cases spiking again, how can we come together and reclaim our unity? How do we help each other get through this? So to try and answer that, we've invited two medical superheroes who have gone through this on the front line, right in the midst of it, but from very disparate settings. One from Bellevue Hospital, which is the oldest, largest public hospital in the United States, complete with a prison, a courtroom, a psych ward, a high school, and 850 beds, which I think ballooned up to about 1,100 during the height of this crisis. And then we have St. Luke's Wood River Medical Center with about 25 beds. But both have the distinction of having the highest per capita infection rates in the U.S. within weeks of each other. So that's where we find ourselves. Let's dive into the discussion. Terry O'Connor. Terry O'Connor is the EMS director, medical director at St. Luke's Wood River Hospital in Ketchum. He's a practicing emergency physician, assistant clinical professor of emergency medicine for the University of Colorado. And to say he's an outdoor enthusiast would be a major understatement. He's had enough outdoor adventures to make John Krakauer jealous. He's been a ski patroller, rural ambulance EMT, bike guide, ultra marathoner, firefighter, and as you can see by this picture, he even made it to the top of Mount Everest. So need I say more? Lisa Wing, who is the head nurse at the ER at Bellevue Hospital in New York, and she's been there for 30 years. Lisa has committed herself to providing compassionate care for the most underserved and diverse patient population in New York City. And she's provided care during some of our most traumatic times, whether it was the AIDS epidemic, 9/11, Hurricane Sandy, or now during the COVID-19 pandemic. And full transparency, Lisa is the technical director on our show, New Amsterdam. She saves us from making really silly television when it comes to medicine. So publicly and for all to hear, thank you, Lisa. So I want to start out by having you both set the stage. I want to ask you both to walk us through your journeys from the beginning. Give us an insider's view of this pandemic, trying to humanize it, take it out of politics. So I want to start with you, Lisa, and if you could give us a sense of when, as this was coming at you, did you start to realize the gravity of it and how big it was going to become?
I think actually early on, we thought, I was talking a while ago, we had one case coming in that, we were all prepared for. We had a room to go to. It was one case. And within a week of that, the entire ER was filled with potential COVID patients. And so we really kind of didn't see it coming, and we just found ourselves in it. I know we were saying, yeah, it's coming. And people, we had some clusters, up in Westchester, and, but it really, truly hit hard and fast. And it was certainly a challenge for us in so many ways. It was ED nurses who all of a sudden became, critical care nurses, because now we had all these ventilator patients in the emergency room for weeks at a time. Basically, we turned the ED in, areas of the emergency department into critical care, ICU, and at the same time had to maintain the non-acute, regular ED type of patients. So we kind of changed the footprint of the ED, and we had nurses and respiratory therapists and social workers and physicians and people from all over the country who really kind of came to New York City to help. And we certainly got our share of help. I think we had up to 60 nurses at one time in the ER, and we couldn't even see each other. We were all in masks, and, you saw our eyes on everybody. So, really an amazing thing looking back. I don't know if during the event that we actually knew what we were doing. We were just kind of moving forward, and learning as we move forward. And here we are today. We went from 100 miles an hour to 0 because, we don't have many COVID patients coming into the ED at all, like we had in the end of March and April, and certainly not the acuity that we were seeing then.
Was there ever a moment amongst yourselves? I mean, you're in the ED doing, you know each other well, and this is starting to build. And was there a moment where you looked at somebody and said, "Oh my God, this is so much bigger than I realized"?
Many moments like that. I mean, for many of the staff, I had staff come up to me. One of the nurses, he said to me, "What am I going to tell my wife? How am I going to tell her I'm coming here every day?" She was newly pregnant. And we just looked at each other like, "Oh, what are we getting?" Yeah, this is, so many times looking at it like, what are we in the midst of, and how are we going to handle it? What are we going to do moving forward? So many moments like that. A lot about how do I go home to my family? How do I continue on here? Day after day, we had, staff that got sick, that went out on leave, that were COVID positive, that came back. Most of them came back as soon as they could. I think there was a real commitment to fighting the fight.
All right, Terry, how did it start with you? When did you start realizing that this was a bigger deal than you thought it was going to be, or did you always see this coming, or what was it like for you guys in Wood River?
Yeah, as far as seeing it coming, it's an interesting question because I think the evolution from skepticism to worry to raising the alarm to then being so in it and even feeling behind really escalated at a pace I've never really expected to ever see in my career. I mean, we're talking like a week. You mentioned skepticism in your family and friends, and I'll admit I started as a skeptic thinking that in little old Idaho, a very non-densely populated community in the United States, nestled, here in the Rocky Mountains, that we probably weren't going to see this thing, right? It was a foreign disease. It was in a foreign place. And I was working off a construct of understanding these infectious disease threats and the paradigm of things like SARS and Ebola. And, a lot of these things, they were self-contained and they effectively kind of burned themselves out, or we would figure out how to contain them. And knowing the way that the Chinese could potentially institute measures to contain it with the type of government they have and national systems that they have, and what they were doing, I was fairly convinced that it was going to stay contained. And so that's kind of where I started. But thanks to one of our commissioners, and I think him to this day, Jacob Greenberg, he kept sending me, he's one of our county commissioners. And so my role as a medical director for the county is I'll field questions. And he kept sending me email after email, worried that COVID was going to come to Idaho. And I felt myself initially being very dismissive of it and then trying to reassure him, right? And I was using data to reassure him based on kind of how things played out with SARS and Ebola and why I thought it wasn't going to come here. And I was working off constructs of things that I've seen before, right? And I think that's a real key lesson that will play out as we get into later on in our discussion here. But I was trying to fit this in a framework of something that I've seen before in my career or I've heard about in my training. Clearly, that's not what we ended up experiencing. But this just kind of disquiet in myself kind of built up because he was concerned. And I realized, I just had a moment of kind of, I guess, introspection and reflection. I'm like, wait a minute, I should probably be validating his concerns here. There's something about it. And I started to look in a little bit deeper, and I started to capture some evidence that really began to worry me quite a bit, that actually it could come here. And probably the most alarming were some of, not the scientific data, so to speak, but some of these really convincing anecdotal pieces of evidence that were coming out. One that made the New England Journal of Medicine from Germany, where this physician, Camilla Rothi, hopefully I'm pronouncing her name correctly, she had diagnosed the first patient in Germany with the disease. And they realized that the only potential contact was a colleague. This guy was in the auto industry and had a colleague from China come over. And they figured that was the only way they potentially could have gotten the disease. But that woman was totally asymptomatic while she was visiting in Germany. So she was never sick. She developed symptoms 2 days later after returning to China, and then this businessman got sick in Germany. And so it was the first kind of anecdotal evidence that perhaps there was asymptomatic spread, right? Which is a huge game changer. Like, we can allow people to self-monitor and spread and help the spread of the disease. If people know they're sick, then they're going to isolate and keep other people from being sick. But if you have a disease that's hanging out in the body and it's being able to be spread from one person to the next, and you don't even know about it, then we have a huge problem on our hands. And so that began to alarm me. Then I heard about this cruise ship called the Diamond Princess, right? Then I found out about the first case in Washington State, where I have some colleagues that work in Seattle that confirmed that there was community spread and had no known sick contacts with connections to Wuhan. And then I got really concerned, and I got really alarmed, and then began this kind of full speed sprint to try to raise the alarm to convince people that we got to be ready, and this might actually come here.
And then it hit. And then
literally from that day, right? Yeah, there were a couple meetings. There were I did a few educational sessions for some of my crews. And then literally a few days after we were trying our best with partnering with public health agencies to convince city leaders and businesses to cancel big events. We had a film festival that was on deck to come in here. With ski season was still in full swing. And we were trying to really convince people and fire the warning shot that we might have to start canceling these things. And then 2 days later, we had our first confirmed case here in the county. Then we had a second. And then I went into a stretch of night shifts. My second night shift, after our second confirmed case, it was just remarkable. It was like there was no warning. I started my shift. Within 5 minutes into my shift, a patient of one of my colleagues had a cardiac arrest while she was in the CT scanner being worked up for a gastrointestinal illness, diarrhea, right? SARS-CoV-2, as we knew it then, the coronavirus, it wasn't a diarrheal illness, right? People were dying because they were having respiratory failure and they'd get intubated, right? That's what we knew at the time. So it couldn't have been this case. She was being worked up by the physician prior to my shift, and she had a cardiac arrest in the CT scanner. So dutifully, as most emergency personnel do, we ran in there en masse. There were like 17 different people that got into that room, and thankfully she was successfully resuscitated, and the team was able to save her life. My partner finished his shift. It was a snowstorm that night, so that patient was effectively in critical care, but being managed by me and my team for an additional 3 hours. So I was managing the ventilator during that shift. But at the same time, we began to have multiple people come in worried that they might have coronavirus and needed to get tested. What that does to a small emergency department is introduce this concept of decontamination procedures, which effectively shut down each ER bed for up to an hour and a half to 2 hours after these visits. And then I lost two of my nurses right in the middle of that shift as well, because I found out.
How many nurses do you have to begin with?
I only have up to 3 or 4 at most at a time. So I'm in a small little critical access hospital, and I find out from infection control that the two of my nurses had to leave in the middle of the night because they were connected to one of the recently confirmed cases from just a day before. They were connected and exposed, and so they had to be quarantined. So we had to quickly muster up resources to replace them. I was working with new nursing staff. And then on top of this, all the while I'm working this shift, I'm transitioning in and out of personal protective equipment, full gown, the mask, the gloves, the N95 mask, more than any other shift in my career, guaranteed. And I know Lisa can say this too.
Absolutely.
Right? I mean, it's just, we have never had to switch in and out of PPE so many times until coronavirus has came into our world. And on top of all that, I didn't know that this patient that I was managing on a ventilator, she ended up turning out positive for the coronavirus. And I didn't know it the whole time. So, the sickest of my patients there, I just didn't even know.
You made a statement to me earlier. I think it was in a discussion with the producer Neil Baer, where you said that in this situation, I want to give this to you too, Lisa, as well. The personal is becoming professional. The professional is becoming personal. What do you mean by that? I want to have a sense of what this is more like for you personally.
Do you want me to start with that, Peter? Or?
Yeah, why don't you start? And then we'll
I think what Neil was getting onto, and this was spurred by, this was in a conference with a number of other colleagues that have experienced coronavirus all throughout the country, and we were sharing our experiences and stories, and how we're communicating these stories to help effectively bring best stewardship to this crisis we're facing. And we've discovered that obviously not only do we bring the risk of this disease home, and that created a whole separate level of anxiety out of our workplace. You know, our solace and our refuge when we punch the clock, we're shift workers. We go home and we can carry on with our lives at home. We were bringing work home with us, potentially. That affected us really personal. And so in a lot of ways, there wasn't this respite throughout this whole time, even though you were off shift. So the professional became personal. And then I think part of the reason we're here, and what Lisa and I have had to do so much, likely in our jobs, is become communicators of how real this problem was, because we were reliant on the behavior of our communities to basically save us. Right. And we had to communicate what we were experiencing professionally, what we were seeing professionally, to make it personal for everybody else. And we had to share what was going on in our personal lives to make it relatable. So that's effectively what Neil was kind of getting onto. And it seemed to be a really shared common experience for all medical providers.
Yeah, talk about that, Lisa. How is the personal and the professional merged for you? And also address, if you can, what is it like for you in the midst of this to hear people in the country saying things like, "Oh, this is being exaggerated," or not wanting to wear masks. Masks is a whole other.
Yeah, I don't understand. Yeah, from my point, I don't understand how people out in this country could think that wearing a mask is a joke, or not having to social distance, or if they had seen what I think New Yorkers, and you have seen, Terry, too, is they would never have that comment, "I don't need to wear a mask," because it affected everybody. There's probably not very few, if any, people in New York City that could say they didn't know somebody who was affected by COVID, or somebody who died from COVID, whether it's a mother-in-law or father-in-law or aunt or uncle. So New Yorkers, I think, really rallied around saying, "Hey, we have a real problem here, and we need to do something." We couldn't have gotten where we were today without the community acting, without people wearing masks, without people sheltering. New York City was a ghost town pretty quickly. Within 2 weeks, I want to say, mid-March, once the St. Patty's Day parade was canceled, Times Square was empty. So I think New Yorkers really kind of rose to the occasion, and they were afraid. And it was real because it was here, and probably because they knew of somebody who was sick, or they knew somebody who was hospitalized that family members couldn't go see. And I think
it's such an
they really did bear down.
Point. Yeah.
I think.
Go ahead.
And for bringing it home, it was hard to come home from work every day. It was hard at the end of the shift to say, "Oh my God, I've been covered in this all day." And you have, and we've changed PPE constantly, and you do all that. You still feel like, you were in the middle of it. At one point I had told you, Peter, I actually had my son come in to the hospital to get tested, and the guilt I was feeling, the guilt that, did I bring something home? Because he didn't get it anywhere. There he is. He didn't go out. So the only way he could have gotten it was from his mother bringing it home to him. So fortunately he was negative. But those are the kind of things that a lot of the frontline workers were feeling. Many of the people that worked at Bellevue were offered to be put up in hotels, which was huge. So anybody who really didn't want to go home, who felt uncomfortable going home, could stay in hotels in the city. And many people did. I kind of personally felt like I needed to get home to my family, because that's what got me through it. Getting home and getting away from it was a good healing part of my day.
Yeah, you hear stories of doctors sleeping in their cars or things like that to stay away from the films. I read a story, I think, yesterday about a guy who's camping in his backyard to stay away, and he'd peek through the window once in a while and see his wife sleeping. I mean,
Yeah.
The price that you guys are all paying for this is got to be something that we have to be taking in and seeing and responding accordingly. So one of the things that occurs to me is, because I want to get to also what's inspiring or inspired you, got you through all of this. But one of the things that occurs to me is this disease is unique in terms of patients in that it's isolating. In New York, there's 8 million plus people, so most people are strangers when they come into a hospital. But in Sun Valley, most people probably know somebody at least who knows somebody. And yet, in both cases, it's kind of a great leveler because patients in both places have to go through this at their most vulnerable times without their friends, without their families. How did you? Let's start with you, Terry. How did you guys compensate for that? How did you respond to that? How did that affect you? How did that impact you?
Yeah, it was a novel challenge. I don't think there was a good solution for it, to be honest with you. A lot of it was us just confiding in one another our challenges with it. One of my partners who actually contracted the virus and was sick, close friend of mine, the reason why I came out to this job from my first job in Portland, Oregon, he got sick. He was home with the illness. He recovered and he came back to work. And one of his first cases he had to manage was a critically ill elderly gentleman that he had to intubate and was very likely going to die. And his spouse was, basically having to stay in the waiting room. And when we know a patient has a very slim chance of making it, priority number one is getting the family in there. I mean, there's good evidence, there's data that shows that both families manage better, but also emergency medicine personnel manage better at the end of life in a resuscitative effort to have everybody in the room. There's actually been good data and studies doing this that show that there's less risk of depression, PTSD, and anxiety in the surviving family members, but also the caregivers, if everybody's in the room at that critical juncture when someone's life may be at the very, very end. And the inability to do that for my partner was really, really trying for obvious reasons, because we just don't feel like we're giving good care to that patient at the end of their life. And when I intubated a patient that came in who wasn't there wasn't an obvious connection to someone in the community. He was found by a well-meaning kind of safety check neighbor who would knock on the door and just didn't answer. Didn't have any immediate loved ones at the time that I knew of. And you think our training is to put them on a ventilator and save their life when they're at this precipice of going into totally respiratory failure. And okay, I'm going to save their life. But with COVID, we feel like, gosh, we might just be prolonging the inevitable. The initial data on people on ventilators was really, really grim. And then you think, this guy's going to go off to a critical care bed, be on a ventilator, and maybe his family doesn't even know where he's at, or nobody's going to be there with him. And then on the other end of the extreme, I had a 20-year-old patient who I admitted, which I initially saw and then handed off to my partner, and he ended up having to be admitted to the hospital. Kind of a unique case because we don't hear about 20-year-olds needing to be admitted to the hospital very often. But he needed some respiratory support. He was in a lot of pain. And what he commented on afterwards, and actually got traction with NPR, he became a feature story on national with NPR, was the isolation. He would not even see a nurse for 6 to 8 hours at a time, right? For obvious reasons, right? I mean, because of the PPE precautions, but it was super, super challenging for him. And there wasn't a way to break that down. I mean, we had to take care of appropriate precautions, and there wasn't really a good solution for it. But the only thing is just to share the stories amongst ourselves to make it a common experience.
Oh, so you were able to just comfort each other by going through this together. It was part of the way you dealt with it. I also know I heard a story that some doctors would put, because you were all in PPE, coming to a patient, and some would put a picture of themselves without it on their lapel.
Yeah, it was a tactic. I would kind of work with these critical care grand rounds sometimes with the Seattle program, the University of Washington, and they were doing that at their facility. They actually they'd print out big pictures of themselves, and they would literally just clear package tape it on top of their gowns because they were just in their gown all day long. And people would just never see their face. And that's unfortunately a bit of the stark reality of where we're at right now. I mean, I'm fairly reconciled to the fact that no patient of mine in the ER is going to see my face for a couple of years. Who knows?
Wow. Lisa, you talked a little bit about some of the ways you coped with that reality of people having to be in there alone. Can you share some of those stories with us?
So as I said earlier, emergency department, usually episodic care, you admit somebody, they go upstairs, maybe 8 hours or within a day. But now we had this huge, I think at the maximum we had 26 intubated, ventilated patients who were staying in the ER for weeks at a time. So, and without the families able to come in. And the big challenge too for them is being New York City, all the hospitals were working together. We took a lot of transfers from the outer boroughs. So from Bronx, Brooklyn, Queens. So now we've displaced them too. So we have patients in our care in Lower Manhattan. They could be from anywhere in the city, and family couldn't come in and see them. We did, I'll have to admit, as it went on and there were some stories where, we knew we had to get some family members in there. It was, in particular, there was one daughter and it was just her and her mother. So by the second week, we had her in scrubs. We did a quick assessment of what the risk for she would be. She had no medical problems. So we got her in scrubs. We put her in full PPE, and every day for the week before her mom died, she sat at her mom's bedside. And, we had to make that happen. There had to be some human, ability there just to not have somebody just die on their own. And for the girl too, for the daughter too. We did, as we went on, there were other families that we would let them in one at a time because we knew the person wasn't going to make it. We knew it wasn't going to happen. What we also did though is we did cell phones every day at the bedside. Nurses would put cell phones at, the pillowcase and let the family member just talk and talk and talk. Some family members sang, some family members said prayers, whatever worked, even though the patient was on a ventilator. So whatever we could do, we tried to do. And we kind of, we took on that role, we hope, of their family. When people were dying or close to dying, we stood by the bedside. We just stood there, and held that patient's hand, or, the staff was incredible, as far as kind of just learning how to do those things.
You talked about an Italian woman that you were singing to at one point. Can you tell that story?
At some point, things had changed. We kind of went through these waves, all these walk-in cases, and then all the intubations, and then all these sick people. And now people were starting to get extubated. They were going to take the tube out, and they thought they were doing better. And for those very few that were going to get extubated, we would get excited because now you've worked really hard for a couple of weeks, and this person has become somebody every single day you're with. So there was one lady, she was going to be extubated, and we were all so excited, and one of the nurses thought she spoke her native language was Italian. So she had Italian music in her cell phone, and everybody was trying to sing Italian music, happy, uplifting music. Turns out she spoke Spanish, and she did get extubated, and she did get discharged a couple of weeks later, and we all met her in the lobby to say goodbye. So, there were a lot of stories like that.
What about the PA system? Tell me that story.
So the PA, so for, the bad part of it was these rapid responses all over the hospital. And that's all you heard on the overhead PA, rapid response. And we all knew that meant somebody wasn't doing well. And then 3 weeks in, we started to hear, and I remember the first time I heard it, the song Journey Don't Stop Believing is played through the whole hospital. And I stopped, I'm like, what is that? What's going on? And it was the hospital's way of telling everybody that somebody was going to get extubated, that somebody was coming off the ventilator because they were doing better, because they were probably going to survive, hopefully. So every time you heard the Don't Stop Believing song, you're like, yes, another one is doing well. Somebody else is doing well. And when we extubated in the ED, the first thing we do is run over the phone. Oh, play the song for us, because that was our patient. So it really, there were things that the hospital did both for patients and for the staff that really made a difference.
If you can, I'm going to ask you about the word awe. It's something that Terry has mentioned. And if we can, because what I want to also get is how you guys get through this or got through it at its worst. And while we're talking about that, we're going to show you some of the signage that you both would run into on a daily basis. It's going to show up just so everyone can enjoy the signs as they come. But Terry, you have a TED Talk that's fantastic, where you talk about the connection between awe or adventure and altruism. I think you say it helps us bind to others, helps us act in collaborative ways. It orients our actions to the lives and needs of those around us. Can awe help us here? Can you find moments of humanity? Did you find moments of humanity? And you've already talked about moments where we come together to try and help a patient as a group, help each other as a group. Were there any moments in this that either of you would describe as awe? I mean, I think there's the flyover, Terry.
Mm-hmm.
There's the wolf howling. There's the clapping, Lisa. If you guys could just sort of talk about the word awe as we're showing these signs of support, that would be great. Why don't you go first, Terry?
Yeah, absolutely. There were moments of awe to really relish later on, I think, in this pandemic. The point from before with awe that you referenced, I think the best way to relate it to the pandemic is it's a big life interruption, right? And I think we have a tendency in our day to day and to get a sense that we have a sense of control in our lives, and that I got to go to work because then I can make a paycheck, and then I can go home and I'll get some groceries, and then we'll get in the car and we have our weekend plans coming up on Saturday where we're going to go to the lake and go camping. And for the most time, those days, they just keep running together like that. But the reality is as we know, as we get older, is that really life is a lot more like one big earthquake followed years later by another big earthquake and small little vibrations in between, right? And I think some of the most formative experiences that I talk about that bring people together or maybe orient you to altruism, are a lot of times still drawn out with these really memorable kind of catastrophic interruptions. And sometimes they're intended. So you referenced, climbing Mount Everest. I think that could be thought of as certainly an awe-inspiring experience, and certainly was intended. It had some additional effects that were unanticipated because of that. But I think, unfortunately, interruptions can be unexpected and sometimes catastrophic. Superstorm Sandy, right? Hurricane Katrina, Typhoon Haiyan, right? I mean, there's all these things that become opportunities to orient people together because it breaks them out of the mold of their everyday, and they start to think about kind of this moral economy in their lives of taking care of one another. And that's actually what's most important, because it's all of a sudden everybody's having this shared interruption in their life, and they have to navigate through that. And therefore it becomes this really important opportunity. Nobody saw it coming. Here we are, and the only way we're going to get through this is together. Mm. But something has to make that switch. Something has to make it real for everybody. I think what Lisa hit on, and what happened here too, is for reasons because of connectedness within the communities and the scope of the problem per capita, whether we liked it or not, everybody was 1 degree or 2 degrees separated from someone who was directly affected by this disease. And that caused a paradigm shift where people stopped thinking about, what was best for them every day to what was best for the community. And that, I think, played out in a lot of community support. And really, I think I was blown away by starting to see some of these signs show up at the hospital. There were social media posts and people were thanking us all around, and then culminating into a common experience that I'll let Lisa carry on from here. And that we had an 8 o'clock howl, very Idaho. Every night at 8 o'clock, everybody would get outside and just howl in appreciation for the healthcare workers. And you could hear it from the mountaintops. And that was a real remarkable, really, really meaningful thing for the healthcare community. And there was something similar going on in New York too.
Yeah, tell us about that, Lisa.
So I think as a community, New Yorkers really felt the need. What can I do? What can I do? What can I do? And somehow out of what can I do became this 7 o'clock applaud for all frontline and essential workers. And it's amazing. I hadn't heard it. I had heard about it. And I think about 5 weeks in, I walked out of the hospital at 7 o'clock and heard it. And for me, that was an moment. What a crazy place, Lower Manhattan can be. And there you have thousands of people on their balconies with blowhorns and bells and everybody clapping. They still do it. They still do it. And so it's really, I can speak for you New Yorkers. They really kind of band together and said, hey, we can do this together.
It's amazing. So we're kind of at the end of our time, but I want to have you answer one last question, and then we have a little bit of a treat for everybody. Just what can you guys, from your perspectives, leave us with that could help us come together and help us be resilient? Any thoughts briefly as we end this? I
really think that, I think Terry hit on this too, when at the time that these things happen, everybody kind of bands together, and we really can't let that go, throughout the country, throughout the world, is that this is one for all and all for one. This is not just, this didn't happen in another part of the world that we're protected against it. Nobody's protected from it. And the only way to battle this is together.
Beautiful. Terry?
Yeah, and I guess to carry on that, to keep motivated, we talk about something Lisa and I know about quite much as well about is signal fatigue, alarm fatigue. We deal with bells and alarms at work all the time, and it's a bit of a risk. We start ignoring those alarms because they happen all the time, and I think we worry about alarm fatigue in regards to awareness about the risks of coronavirus, and I think that's normal and that's expected. I think healthcare professionals and even the news and the way that they're covering this, we have to be careful about trying to motivate people with statistics and the numbers and the case fatality rate. When it comes to acting and actually inspiring people to act, it's really not enough to know. It's everything to feel. Right. And to feel, we have to tell stories that resonate with people. And sometimes we have to not let us be the one telling those stories, because there's trusted messengers within your community, and you have to have those people tell their friends. And I guess I'd just leave with a great quote that I always remember from Melissa Fleming, who was with the UN High Commission on Refugees. She said that statistics are human beings with the tears dried off. And, these stories that we are fortunate enough and have the privilege to experience because of what we do, they deserve to be shared. But you don't have to be a doctor to share those stories too. People are affected in their own private lives with dealing with family members that fell ill of the disease, or maybe having a loved one who's a frontline essential worker who works at a grocery store. Right. And talking about your experience, how it's impacted you emotionally, really will resonate. And it spreads, that message does spread exponentially just as much as viral contagion can. So there's an emotional contagion that we need to we need to take advantage of to really effectively fight this going forward.
Beautiful. So we're going to take a moment, all of us right now, to experience togetherness, what it's like. And so just take a beat and take this in, and we'll come say goodbye when it's done. Hang on. One more. And there you have it. The power of togetherness and what we can do if we unite. Okay, Amy, I think you have, first of all, thank you so much, Lisa and Terry, for joining us here and doing this. This is so moving and so great to help us understand what it's like to be in the middle of this, where it's really, really happening, and why we all need to be there to support you. So, going to a question and answer thing now. You have something to tell us about that, Amy?
I do, and thank you again to all of you, Peter, Terry, and Lisa. Thank you. Thank you so much for everything you do all the time, every day, that we can only get a taste of today, what you've been through, what you're going through, what you'll continue to do with your service. So grateful to Terry right here in our community, and Lisa in that one that's been hit so hard. So thank you. And thank you, Peter, such a storyteller, and really just thank you for being part of helping think the narrative around this and helping people to understand and connect as people. That's what it's all about. So thank you very much.
Of resilience, right?
Yeah, and I'm actually going to ask everyone to stay in this room for the Q&A with Peter and Lisa and Terry, so we don't need to go anywhere else. Make it simple. And so ask folks to stay for the Q&A here. And then we have, at the same time, two options. One, we have the speed networking to just go into the room and get placed one-on-one for 5 minutes at a time for the next half hour with people to meet, spontaneously connect with. Or secondly, to join the networking rooms that are being hosted by our partners and advisors who provided updates earlier in the day. So a lot of you have signed up already for those networking rooms. And so if you're in one of those rooms or want to do the speed networking, just go to the bottom to leave the room, leave this end the session, and then join either the networking or the room that you've been assigned to. And if you're not assigned to a networking room and you want to join one, please go ahead and do that email to Mike Gordon, and he can add you to the room of your choice, which is on the dashboard for Run the World. So it's forum@sunvalleyinstitute.org is the email for Mike to get that done. With that, I will stick with this crew, and we'll let everybody go back. And then if you go to the other rooms, please do come back at 4:45 or so, 4:50. Let's give ourselves a half hour for the Q&A and discussions and networking. At 4:50, we'll just do a wrap up, and we'll bring back the folks who, a handful of our great advisors and partners, to join me in doing a wrap up with everybody and talk about what we'll be coming back to in July, later in July. So thank you again to our panel. Thank you so much, and thanks to everybody.
Okay, you guys, you ready for some questions? That was really, really great. Thank you both so much. It was so, so powerful, and I just think healing on such a big level. Okay, we have our first question is from Liz Keegan from Blaine County Housing Authority. She says, I am worried about those who have been hospitalized and are not yet fully recovered. What follow-up would Dr. O'Connor recommend?
Yeah, this is, again, another arena of we don't have great guidance. And, this is where a bit of a challenge for us as healthcare providers is we've had to err on the side of being conservative because we don't have good evidence to fall back on. There's a couple different ways to interpret this question. One would be someone who's actually still symptomatic and still ill for weeks and weeks on end. There have been documented cases where people are sick, 6 to 8 weeks at a time, and that's extremely unfortunate. But it does happen. And Lisa's nodding her head that she's heard and seen this as well. And unfortunately, that the answer there is they have to be if they're sick enough that they need to be evaluated in a hospital setting and potentially hospitalized. That happens. We've had what we would call bounce backs, where we send people home. We thought they didn't need medical care, and then they come back feeling more short of breath, and lo and behold, they actually need more supportive measures that the hospital provide that we couldn't provide for them at home. The other question is people who are still turning out positive for weeks at a time after their symptoms have resolved. It's hard to know what to make of that. Right now, we're unfortunately in a position where we have to treat them as still potentially contagious. And we have to isolate those people appropriately. But I think there will be a body of evidence that will be a bit more robust to come that will show that perhaps at a certain stage we can prove when someone's really not going to spread the disease around anymore. And it won't be purely based on these genetic-based tests. We might just be finding, the leftover genetic material of the virus, but it's actually not an active, viable threat anymore. These are things that we're working on multiple research projects across the nation, including here.
So much unknown, right?
Yeah.
At this point. Julie Wrigley, who's the president of Wrigley Investments, asked, what time frame was the first recognized case that came into the Valley? What was the time frame for that? Yeah,
I think there might be an answer. Someone offered an answer, I think, mine right below there too, which was about right. We 13th and 14th. 14th were the first two reported cases. Again, remember, probably the key thing about that, which Lisa might have some comment on this as well, is that that's when they became positive, but it certainly wasn't when they were symptomatic, when they had the onset of their symptoms. Remember that not only did people really have on their radar screen that they might have coronavirus when they got sick, because we had all these other things called colds and flu, right? Which is what people historically would attribute these feelings to. But the reality is they got sick, at least in this community, on March 1st was probably our first confirmed case actually got sick, started feeling sick on March 1st. And then there's this huge lag time between when we actually can get them a test and then when we can get the result of the test. So we might have actually tested someone on the 7th, but we don't get a result and unfortunately, when we were in the worst of it and when we had real testing capacity issues, we'd have to wait 10, 14 days to get a result that someone was positive.
What's it like now? What's it like now?
Much better. But yeah, I'll let Lisa to share her experience a little bit too.
Yeah, testing is much better right now. It's still a challenge. But initially, we weren't testing everybody who came in symptomatic. We just didn't have the capability to do it. Patients that were getting admitted were getting tested, and we had a 2 to 3 day turnaround time. So we weren't testing everybody, and we were discharging people home. And then, as Terry said, then you had this group of people that came back 7, 8 days later, in respiratory distress because their symptoms had progressed. We now test. We have certain tests we're limited. We can get a rapid turnaround in 2 to 3 hours, but that's limited for us in the number of patients a day the hospital can do that for, and it's a 2 to 3 day turnaround for everybody else who gets admitted.
Wow. Yeah, boy, that's a key, right? I mean, testing. And are you using those turnaround tests also for yourselves to make sure you're okay, right? You, hospital staff, or is it just for patients?
We at Bellevue aren't testing hospital staff unless they request to be tested. I mean, certainly they're getting tested, and anybody who's symptomatic. But that's really at the choice of the employee.
Okay. Andrea writes, I just read that Idaho ranks last in the amount of COVID tests that hospitals have. What would you recommend? Folks who have not been confirmed to be tested? Is there any time frame on when testing will be openly available for everyone? So it's in the same vein.
Yeah. So in an area of frustration that we dealt with here as well, not any one particular person's fault, but I mean, I think it's something that was in the news and ended up being a real personal frustration for a lot of us as physicians and nurses. I mean, our nurses that would eventually staffed our drive-through tent testing, which solved the problem of contaminating all these ER rooms that I dealt with, that I was speaking about. We still had limited capacity of testing in our peak of our surge. And so you would only test, say, one member of a whole household, even though there might be 3 people sick, because if you find that one's positive, then you just say, well, the rest are probably positive too. Or you would only test one person in the car, because you'd say, well, if that person ends up positive, then everybody else in that car can consider themselves positive too. These were some of the not so palatable things we were having to do to try to conserve resources. Now, we've been able to expand testing criteria a bit, but what Andrea is getting onto is something that I'm trying to work on with a number of innovative partners here. This little county captured a lot of interest when it hit the news because it seemed a bit improbable, and there were some interesting dynamics that I think brought it here in such such high concentration that, you know, we garnered the interest of really the Vaccine Trials Network and some really well-esteemed researchers in virology at the University of Washington, and also the Amazon Science Innovation Team. And we're working effectively, and also with our local hospital foundation, to work on some innovative projects to basically help bring testing here to the community. But it's supported in academic investigation. If you think about this, the country as a whole, and the fact that we need to conserve resources when we have hotspots, it doesn't really make sense to be testing people if they're asymptomatic, just to see if they have the disease, or even testing to see if they have antibodies to inform some sort of practice for that person, because we don't really have the data to say what to do with it yet. But some things that we're going to do, just to come back to what Lisa was mentioning before in your question before, I'm working on developing a research project right now where we're going to enroll volunteers who are essential frontline workers. So think about all the people that still had to go to work when we were fully at stay-at-home orders. So these are not just nurses and doctors, but of course the firefighters and EMS professionals, but also police officers, but also grocery store clerks, right? And we're going to allow them to get and to self-test themselves for the virus weekly for the next 6 months. And that's to inform, in addition with a few other analysis, when do you get sick? How many people are asymptomatic when they're carrying the virus? How long do you carry the virus? When do you convert? How do you get immune? All these sorts of things. But it'll have an additional benefit to us of effectively being a surveillance tool. I mean, we're putting sentinels out on the front to see if this disease is approaching our community again before it hits us like a tsunami. We're trying to look for the ripples before the tsunami comes and hits. But it's fortunate for us. You know, we have some motivated people. We have some innovative people. We've got people with connections. And I have to be honest with you that not every community is going to have access to some things that hopefully we'll be able to bring to bear for this community. And really, I think, you know, as the years go by, the tale that will be told about this pandemic, looking through the retrospectoscope, is how crippled we were by lack of access to testing and to speed in diagnosis.
Yeah, talk about that in New York, Lisa. What are you hearing about testing in terms of?
I don't hear much. I just, you know, we are limited. I know I can speak to Bellevue. We're limited in the number of rapid tests we can do. We're limited in the overall number of tests we can do every day, whether they're a 3-day turnaround or a 3-hour turnaround. Concern is going to happen more. There'll be more concern in the fall as the flu season picks up, we can swab and test for flu, all the other flus, how will we differentiate? Is this COVID? Is this not COVID? Originally, it was like, well, if you had a positive flu swab, the traditional flu, then you probably weren't COVID. That's what we were doing. So it'll be interesting to see what the fall brings, when flu season does start to pick up.
Yeah, as you know, Lisa, we're trying to get our production up and running again in New York this fall. And one of the things we're hoping and praying to be able to use is testing, be able to test the crew, test the actors, test the directors, everybody kind of before they come on set. And then there's the whole puzzle of how do you keep them isolated while they're going home, while they're going with their families, let alone on the weekends, where they're going to have to be tested again. And so it's, in terms of industry and business and things like any group, any business that's group dependent, testing is a key to it coming back to work, right?
Yep.
Julie Wrigley asks again, when do they think the earliest COVID cases arrived in the U.S., in the United States? Do you have a sense of that now? I've heard different.
Yeah, that's a good question. I mean, it depends on what evidence you're kind of going off of. There was an intriguing evidence that came out of some cadaver studies from California that thought that actually maybe some of the first cases had gotten into potentially the San Francisco area, as one would presume, being a hub from flight travel from China, as early as December. The first real confirmed case that hit the literature would have been the case of the gentleman who traveled back from Wuhan to the Seattle area. I believe that was January 20th. Would have been that first confirmed case. I think that's still most commonly accepted as the first diagnosed case here in the U.S. because it certainly was attributed to a man with active disease that had a full spectrum, versus we're extrapolating that people that died from respiratory diseases not otherwise specified that ended up being positive for the virus. Hard to know. Still hard to know. Yeah, I mean, so somewhere between December and January 20th at the latest.
Okay. And you guys, I mean, the West Coast got hit first, but the East Coast got hit the most. And as I understand it, that's because of European travel, right? People coming in from Europe to JFK and whatnot. Is that accurate?
That's accurate. And that's, the governor actually spoke again today about that it was really missed that this didn't come to New York from China, but it came from Europe. I can say from a triage perspective, we always do a travel screen, but, December, January, the whole fall, have you traveled from Wuhan, or have you traveled? I think we had a list of 7 countries. I don't think originally any of them were the European countries. So they weren't even on the radar. And it was here.
Yeah, I was traveled down to the Dominican Republic right before this was just beginning to hit. Right. To do some location scouting for one of our episodes. And as I went through customs, the customs agent suddenly, out of nowhere, came up with a mask on. The other ones hadn't had masks on before that. And I went up to him and he asked me, where have you come from? And I said, the United States. And he said, have you been to Italy? And that's kind of when I knew this was not just going to be a Chinese phenomenon. It was like, oh Lord. Okay, Dan Balbach, can you describe some of the learning that has developed about treatment? What have you learned about treatment? Yeah.
Do you want to start with this one, Lisa?
I still think there's a lot to learn. I think, through this whole thing, there's been, different talks about medications working. We're now talking about Decadron working, which is a steroid that, and I think everybody, I think they really don't know yet. I think there's going to have to be a lot of studies and a lot of information coming from all over on what the best treatment is. We were initially intubating everybody, who was hypoxic. Now there's discussion about maybe we don't have to intubate people. I know during it we started proning people, which is, lying patients on their stomach. to help with the breathing, and I saw that work, and I saw that work and avoided patients from being intubated. Not many of them, but a few. So I think there's a lot to learn about the treatment moving forward.
Yeah, those are great examples. And in fact, it echoes a little bit of a trend where we have done a little bit less with better outcomes than more. And I think the initial phases of this, and certainly as I think a lot of people can relate to based on the news cycle early in the pandemic, is there was a real emotional drive that biased even literature to find a therapy for this. I think people were really hot to find the silver bullet here for this disease, and sometimes not even with any evidence at all, with the hydroxychloroquine catastrophe that has been well publicized about now. But at the time, it seemed like people were starting to try to stockpile this, and even hospitals themselves were trying to internally triage their supplies, assuming that it actually was a very useful medicine. As it turns out, we've discovered with the problem with a lot of therapeutics without adequately in studying them is that there's potential real harm versus benefit when you just throw these medicines at people without good evidence. But I won't go into details, but some of the preliminary evidence, it wasn't really well-designed studies and also a lot of suspicion of falsified data with some of these investigators. And so I guess we are scientists and we're constantly skeptical and critical of what we do. And we're happy to hear, or you would hope that everybody in your community is happy to hear ways to do it better. And this is what caused this just surge of online education and conferences that would happen all the time. And we were scrambling to figure out, hey, who's figuring this out and how to do it better. And early in the stages, I was on weekly conferences with multiple different, representatives from different universities. And there was never a big game changer. It never was. And most of the time when we had these conferences, you were talking about, we had critical care docs from Mount Sinai calling in. We had some other ones that are dealing with the pandemic down in New Orleans. And then, of course, the informative experiences of the critical care physicians in Seattle that were seeing it on the first end. And a lot of it was, we were just kind of refining and basically de-amplifying the volume on everybody investing all this information in this therapeutic. And it turned out in the end, after a month went by, I was like, actually, you know what? Turns out we kind of need to do what we already know we need to do, but there's a few instances where we can get away with doing even less. It turns out that they actually do okay. And that's been kind of interesting to see. And that this is this concept of people that have really low oxygen numbers sometimes end up doing pretty well with pretty minimal intervention. And I think the really interesting thing about that is, as I'm sure Lisa's observed, is the ones that do okay are the ones that you look at and you're like, oh, that's just not a sick person. I know what the test is telling me, but that's not a sick person, so I'm not going to treat them like a sick person.
Was that your experience, Lisa, too?
I think as we move forward, yeah, I think that we were intubating everybody who had low oxygen levels. And now, we had at the time, Terry, maybe you can tell me if they did it there. We were so concerned about super spreading events as giving, nebulized treatments or, high flow oxygen, and the lack of our ability to isolate patients because we were so overwhelmed with so many patients that intubation at the time, I think, seemed like the better way to go than these super spreading, treatments that we were doing. And now they're looking at it like, no, it's better to high flow O2, seems to be doing well for patients, for many patients. Although for us, our acuity has been a lot lower. We're just not seeing that acute hypoxic patient showing up at triage right now. We're not, which is a good thing.
It's one of the things that we forget about this. You feel people's confusion often out there. You're hearing this from here and that from there. Part of that's you could attribute to our political leadership, but what we forget is this is a novel COVID event, and everyone's trying to figure this out in real time. And we're kind of watching all of you try and get your hands on this. And sometimes I think for people that can be disheartening and even lead to, conspiracies and all sorts of things. but it's kind of the case, right? I mean, you guys are figuring this out as you go. You're doing the best you can and learning on the fly.
Yeah, I mean, I think it's a challenge you hit on. I mean, I think not many people would argue that we live in a pretty fast gratification society now. And people are used to getting a quick answer and what they want, as soon as they want it. And that really came to a head with coronavirus because we were having to ask people to be patient with us. We were trying to figure this out. And we're not, unlike potentially some politicians, we're not just going to go and, put our money, lay our nickel down on some therapy that we're not sure if there's potential harm with that. And so that as much as we were in a rush of disease, we had to put the brakes on telling people what we could do about it. And that was a challenge. It wasn't that we weren't working really hard, but we couldn't give people the reassurance that I think they all wanted that, we just need to do this. Right. And you can see the desire for that and how it got manipulated by politicians because there was an insatiable appetite to hear that news because it was so emotionally upsetting for people to have this uncertainty in their lives. Sure. Think about the uncertainty that was happening in the medical professionals' lives. That's how I would often answer this in the local community. Like, why don't you guys have this figured out? And then they would, because they're naturally thinking there's some nefarious undertone here and it's a conspiracy and we're all in cahoots with the Chinese government. We want this thing to keep persisting along. It's like, no. If we would want to be through this just as soon as you are. Trust me, we have to go to work, see this every day and potentially bring this home to our loved ones and families. We want to be over this well before you guys. We're not going to take any risks. And convincing people of that is challenging.
Lisa, you've talked about your fear of this returning too. I mean, that you guys, it's like almost a little PTSD of what if, if this were to come back, it's the last thing you want.
It's the last thing anybody wants to see happen. It was devastating. I think it was devastating for people and families. And like I said earlier, there was probably not a single person you can talk to that didn't know somebody that was affected by this. And nobody wants to see this come back. Either a frontline worker or anybody who's been cooped up in their apartment in Manhattan for the last 3 months for sure.
I've got 2 quick questions and then Amy can interrupt us, I promise. One is from Joyce. She says, will we have some data soon on how long the antibodies and potential immunity may last? Does anyone have a sense of that really quickly?
Yeah, we're working on it. We just got funded a project. We're actually trying to get a little bit more funding. We're trying to help inform that body of knowledge with really the Vaccine Trials Network. Lee Corey, who's a principal investigator out of the University of Washington, who really in a lot of ways is Anthony Fauci's right-hand man when it comes to validating those vaccine trials, which a lot of it has to do with if you have a vaccine, right, what you're trying to do is create an antibody and you want to show that antibody has a durable response, that is, it doesn't go away and it actually neutralizes and prevents the disease from getting in your body. We don't have that data. So it's not going to be soon, unfortunately. And we're working on it. We're in the active process of doing it. But this is the same problem, is that science, because it is founded in a critical method and constantly trying to see how we could be wrong before we tell people what we're right, it takes time. And certainly things are moving faster, I think, than historically with a lot of responses and trying to develop therapeutics, but man, I'm not even entertaining a timeline for these answers in my own head because I maybe that's just my bias. Maybe it's Lisa and I's bias as well for the work we do. But I go into work every day and I approach my job expecting very little, and I'm pleasantly surprised. And it's just a way to survive it.
Right.
Do you have time for one more, Amy, or should we stop?
One more, quick.
Okay, this is a quick one from Chris Johnson. Should Blaine County officials mandate mask usage in public, or can we promote the use and encourage our businesses to require usage? It's a volatile one. So
yeah, it's a volatile one. So I actually just had a meeting on Friday. All the city leaders asked me to chime in and give my opinion. And I certainly, based on best available scientific evidence now, yes, I think that we should, as a scientist. And that's me speaking as a physician, as a scientist. Now, we made a recommendation to wear masks early on based on just kind of intuitive feel that this probably was being spread around asymptomatically, people who didn't have the disease, and probably was aerosolizing to some degree in the air, and it made sense. Now that we've kind of fatigued of going through the wave, do we still need to do the same thing? And actually now we have a large body of evidence from all different studies, the whole country of Iceland, the small village of Vaux in Italy, the Diamond Princess cruise I talked about before, which really does prove that asymptomatic spread happens. And if you don't know you have it, and we've also proven that people can aerosolize droplets with the virus with just talking. So you don't have to have a cough, right? It's what you naturally would avoid somebody else. So in order to take care of your community and protect other people from you, if you might have it and you don't know it, then there's great evidence that you should wear a mask. The problem is, speaking as a politician, then who enforces that? It's easy for me to say, yeah, I think we should. And I personally endorsed for what like California did, what Oregon did. But, there's objections that come up, like who enforces it if they don't? Right. Do you call in the police department? Or do you leave it on to the business owners to enforce it? My personal opinion, I think best for my personal opinion, is I think you do a mandate. You say that it is enforceable. There are some teeth behind it. Realistically, probably it won't be enforced by law enforcement, but you will enable business owners to do what they really want to do, but they're kind of afraid to, is say, hey, sorry, I can't serve you without a mask, or I can't let you into my shop unless you're wearing a mask. It's not me, it's my county. They have a backup, but it's actually what they really want. But if you're servicing your customer, you don't want to upset the customer.
Yeah.
Right. And so there's just been some really tragic tales, Peter. I mean, a friend of mine texted me a restaurant tip from when we first opened up, and in the tip line, or a restaurant bill, and it was from a waitress who shared this with another one of my firefighter paramedics. In the tip line, it had 0, and then it said, "I don't like your mask." That as a medical director and someone that's lived through this and worried about it coming back, I mean, that really stings, but that's the sort of pressure I think these business owners and people are coming up against, and it's really, really tragic. So I think encouraging the social modeling of masks as much as possible only benefits the community.
We have the mandate in California.
Yeah.
And Lisa, how's it going in New York? Are they wearing masks there?
You're mandated to wear masks. I think you can't get in most businesses without a mask on. We all have our masks, right? I think a little bit of it, whoever kind of polices it or patrols it, it's for me, it's really about empowering a community to say, hey, you can do something to make a difference here. There will always be people that don't want to pay attention to rules. But if you can say to somebody, hey, you can make a difference. You can make a huge difference in this by doing a simple thing like wearing a mask, then maybe you can get more buy-in. Because the people that don't have buy-in, I just don't understand it. And I guess it's just educate the community about how important it is and the differences that it can make.
On that note,
save a life.
If you guys have your masks, can we put them on and take a picture?
I don't have mine on me, but I have a great Mickey Mouse mask.
I don't know if I have one. I can check my work bag.
Yeah, I don't have one.
I see.
Mine are over in my decontamination station, which every healthcare worker has.
Two doctors don't have
them. Naked in their garage.
I see.
Yeah. This is a moment not to wear one.
Yeah, right. I talked to you before about respite. This is one of the few places in my life I have respite.
Oh, right. And I'm banished to one room.
Yeah, right. Yeah.
Thank you so much, you guys. Peter, moment, I just would thank you all. Thank you all so much for this session. We have a closing session coming up with a bunch of folks returning in to kind of share their takeaways from the networking discussions, the campfires, and the talks, including yours. Thank you so much again for this and for all you guys do. And Peter, thank you for guiding this really important conversation. As Michelle said, informative, heartwarming session that needs to be heard from communities everywhere. So thank you.
You did. Thanks both of you. It was just really, really lovely. Thank you so much.
If you would, would join us for the closing, I'm going to leave and I'll head over to that one. Thank you again.
Thanks, Amy. Thank you, Peter.
Thank you, Lisa.
We leave here and go there now, right?
Yes, we do.
Okay.
We got to
Okay.
Sorry.
Thanks.
Bye, you guys.
All right.